Welcome. In this session, we will go through the diagnosis and management of diabetic ketoacidosis in a clear, structured, exam-focused way. All recommendations are based on the Joint British Diabetes Society's Guideline 2023 for the management of diabetic ketoacidosis in adults, which is the key reference for MRCP and UK clinical practice. DKA is a biochemical diagnosis. In the exam, you must always look for three essential criteria. Criterion 1. Glucose. Capillary blood glucose greater than 11 millimoles per liter, or a known diagnosis of diabetes mellitus. Remember, patients on SGLT2 inhibitors may have normal or mildly elevated glucose, so glucose alone does not exclude DKA. Criterion 2. Ketones. Blood ketones greater than 3 millimoles per liter, or urine ketones 2+ or more. Blood ketones are preferred because they are quantitative and allow monitoring of treatment response. Criterion 3. Acidosis. Venous bicarbonate less than 15 millimoles per liter, and or venous pH less than 7.3. This confirms the presence of a metabolic acidosis. Now bring the three criteria together. If all are present, DKA is confirmed, and you must move immediately to severity assessment and emergency management. If the triad is not complete, think of alternative diagnoses such as alcoholic ketoacidosis, starvation ketosis, or other causes of metabolic acidosis. MRCP exam key point. No acidosis means no DKA. After confirming the diagnosis, the next step is to assess severity. This is essential because severity determines the level of care and the intensity of monitoring. According to the JBDS 2023 criteria, DKA is classified as severe if any one of the following features is present. Look first at the biochemical markers. Blood ketones greater than 6 millimoles per liter. Venous bicarbonate less than 5 millimoles per liter. Venous or arterial pH less than 7.0. An anion gap greater than 16. Now assess potassium at presentation. A potassium level less than 3.5 millimoles per liter indicates severe DKA and carries a high risk of arrhythmia. Next, the clinical parameters. A Glasgow Coma Scale less than 12. Oxygen saturation less than 92% on air. Systolic blood pressure less than 90 millimeters of mercury. A pulse greater than 100 or less than 60 beats per minute. These features indicate physiological decompensation. MRCP exam key message. Only one severe feature is enough to classify the episode as severe DKA. If severe features are present, request immediate senior review. Consider Level 2 care, HDU, and start intensive monitoring. This early recognition is what prevents cardiac arrest, cerebral edema, and multi-organ failure. Now we move to DKA variants and important differentials. These are high-yield MRCP traps and are frequently tested in clinical scenarios. Euglycemic DKA. This is true DKA, but with normal or near-normal glucose. Always think about it in a patient with metabolic acidosis and ketones without marked hyperglycemia. The most important cause is SGLT2 inhibitors, such as dapagliflozin. It can also occur with partial insulin treatment. Management is different in one key aspect. Continue the fixed-rate insulin infusion at 0.1 units per kilogram per hour, but start 10% glucose from the beginning to prevent hypoglycemia. Do not reduce the insulin unless hypoglycemia persists, despite adequate glucose replacement. And if the patient is on an SGLT2 inhibitor, stop the drug and complete a yellow card safety report. Ketosis prone. Type 2 diabetes. This is DKA occurring in type 2 diabetes. It is classically seen in people of Afro-Caribbean or Hispanic origin. Manage using the standard DKA protocol. The important exam point is the course. After recovery, many patients can come off insulin and continue on non-insulin therapy. Differential diagnosis. Not every ketotic acidosis is DKA. In alcoholic ketoacidosis, glucose is often normal. Measure blood beta-hydroxybutyrate because urine ketones may underestimate ketosis. In starvation ketosis, ketones develop gradually over days, and the acidosis is mild compared with DKA. MRCP exam key messages. Normal glucose does not exclude DKA. In euglycemic DKA, reduce glucose, not insulin. And ketosis-prone type 2 diabetes can become insulin-independent after recovery. We now move to the first 60 minutes of DKA management. Time 0 is defined as the moment intravenous fluids are started. This phase is critical in the MRCP exam and in real clinical practice. 1. Vascular access and fluids. Start by securing large-bore intravenous access. Immediately commence 0.9% sodium chloride using an infusion pump. The fluid rate is guided by the systolic blood pressure. If intravenous access is difficult, request critical care support early. 2. Commence insulin, fixed-rate intravenous insulin infusion. Start a fixed-rate intravenous insulin infusion at 0.1 units per kilogram per hour, based on body weight. Prepare the infusion as 50 units of soluble human insulin in 50 milliliters of normal saline. And a key exam point: if the patient normally uses long-acting basal insulin, continue it. 3. Clinical assessment. Record full vital signs including respiratory rate, temperature, blood pressure, pulse, and oxygen saturation. Assess the Glasgow Coma Scale, and perform a complete clinical examination. 4. Investigations. Check capillary and laboratory glucose. Send a venous blood gas for pH, bicarbonate, and potassium. Request urea and electrolytes, full blood count, and blood cultures. Also perform ECG, chest X-ray, and urine testing. 5. Monitoring regimen. Monitoring must be structured and frequent. Check capillary glucose and ketones every hour. Repeat venous blood gas and potassium at 60 minutes, at 2 hours, then every 2 hours. Measure plasma electrolytes every 4 hours. Use continuous cardiac or oxygen monitoring when clinically indicated. 6. Precipitating factors. Always identify and treat the underlying cause. Common triggers include infection, physiological stress, insulin omission, or no clear cause. MRCP exam key messages. Start fluids first. Time 0 begins here. Use a weight-based fixed-rate insulin infusion. Continue basal insulin if the patient is already on it. And remember, hourly ketone monitoring is essential to assess response. We now focus on the initial fluid replacement in the first 60 minutes. Time 0 is the moment intravenous fluids are started. Fluid selection. The fluid of choice is 0.9% sodium chloride, given through an infusion pump. This is the first and most important step in DKA management. Rate determination, based on systolic blood pressure. Next, determine the rate by checking the systolic blood pressure. If the systolic blood pressure is above 90 millimeters of mercury, give 1 liter over 60 minutes. If the systolic blood pressure is below 90, the patient is shocked. Give 500 milliliters over 10 to 15 minutes, then reassess. If the blood pressure is still below 90, repeat the 500 milliliter bolus and seek senior or critical care support early. If the blood pressure improves above 90, continue with 1 liter over 60 minutes. Potassium replacement in the first hour. Now assess the serum potassium. If potassium is above 5.5, give no potassium. If potassium is between 3.5 and 5.5, add 40 millimoles per liter to the infusion. If potassium is below 3.5, this is a medical emergency. You must delay insulin and replace potassium first, with urgent senior review. This is a high-yield MRCP safety point. Critical safety message. Do not add potassium to the first liter if the potassium is above 5.5. This increases the risk of acute pre-renal kidney injury. MRCP exam key messages. Fluids come before insulin. The fluid rate is guided by systolic blood pressure. And if potassium is below 3.5, delay insulin and correct potassium first. We now move to the management phase from 60 minutes to 6 hours, where treatment becomes protocol-driven and target-based. Action 1. Fluid replacement regimen. Continue 0.9% sodium chloride with potassium chloride. Give 1 liter over 2 hours, then another 1 liter over 2 hours. After that, give 1 liter over 4 hours, followed by 1 liter over 4 hours, and then 1 liter over 6 hours. This structured replacement corrects circulatory volume, dehydration, and ketonemia in a safe and controlled manner. Action 2. Glucose management. Now assess the plasma glucose. Ask the key question. Is the glucose below 14 millimoles per liter? If the answer is yes, start 10% glucose at 125 milliliters per hour. At this stage, consider reducing the fixed-rate insulin infusion to 0.05 units per kilogram per hour to avoid hypoglycemia. Remember for the exam, do not stop insulin. You are treating ketones, not glucose. Action 3. Metabolic targets assessed hourly. Your treatment is effective only if the metabolic targets are achieved. You need capillary ketones falling by at least 0.5 millimoles per liter per hour, or venous bicarbonate rising by 3 millimoles per liter per hour, and plasma glucose falling by 3 millimoles per liter per hour. If these targets are not met, first check the pump and infusion system. Then increase the insulin by 1 unit per hour. This is a very high-yield MRCP escalation rule. Action 4. Monitoring frequency. Monitoring must be strict and regular. Every hour check capillary glucose and ketones. Every 2 hours check venous bicarbonate and potassium. Every 4 hours check plasma electrolytes. This prevents missed treatment failure and electrolyte complications. Exam-focused key message. From 60 minutes to 6 hours, continue the fixed-rate insulin, replace fluids in a structured schedule, start 10% glucose when glucose falls below 14, and ensure the hourly ketone target is achieved. We now enter the 6 to 12-hour phase, where the key task is to decide whether diabetic ketoacidosis has resolved. Action 1. Continue fluid management. Continue the standard intravenous fluid regimen. At this stage, reassess the cardiovascular status at 12 hours and actively look for signs of fluid overload. This is especially important in elderly patients and those with cardiac or renal disease. Assessment. Resolution of DKA. Now focus on the resolution criteria. DKA is resolved only when all three are achieved. Capillary blood ketones less than 0.6 millimoles per liter. Venous pH greater than 7.3. Venous bicarbonate greater than 15 millimoles per liter. For the exam, remember this critical rule. Do not use bicarbonate alone to define resolution, because hyperchloremic acidosis from saline can give a falsely low bicarbonate. Always rely on pH and ketones. Action 2. Biochemical review at 6 hours. At 6 hours, check venous pH, bicarbonate, potassium, capillary ketones, and glucose. These results determine the next step. Decision point. Is DKA resolved? If the answer is yes, move to subcutaneous insulin. Give the first subcutaneous dose and continue the intravenous insulin for 30 to 60 minutes to ensure adequate overlap. This overlap is a high-yield MRCP safety point. If the DKA has not resolved, review the insulin infusion rate, ensure early diabetes team involvement, seek senior specialist advice, and check for problems with insulin delivery, line patency, or a new precipitating cause. Hyperchloremic acidosis warning. A final important warning. Large volumes of 0.9% sodium chloride can lower bicarbonate and mask true resolution. So again, base your decision on ketones and pH, not bicarbonate alone. Exam-focused key message. At 6 to 12 hours, confirm resolution using ketones, pH, and bicarbonate together. Start subcutaneous insulin with proper overlap, and if targets are not met, escalate early and look for the cause. We are now in the 12 to 24-hour phase, where the expectation is complete biochemical resolution of DKA. Expectation at 12 to 24 hours. By 24 hours, DKA should be resolved. At this point, the patient should be eating and drinking, back on their usual insulin regimen, and ready for conversion to subcutaneous insulin. For the exam, failure to achieve this is abnormal and must trigger urgent review. Resolution criteria. All must be present. Resolution is confirmed only when all criteria are met. Blood ketones less than 0.6 millimoles per liter. Venous pH greater than 7.3. Venous bicarbonate greater than 15 millimoles per liter. And the patient is clinically well and eating. Decision pathway. Pathway A to DKA resolved. If DKA is resolved, move to subcutaneous insulin. The key safety step is give the first subcutaneous basal insulin before stopping the intravenous insulin. Then continue the intravenous insulin for 30 to 60 minutes after the first subcutaneous dose. This overlap prevents rebound ketosis and is a high-yield MRCP point. Pathway B. DKA not resolved by 24 hours. If DKA is not resolved by 24 hours, this is unusual with correct treatment. You must actively look for a cause. Common reasons include gastritis preventing oral intake, inadequate insulin infusion or pump failure, an untreated precipitating factor, or a missed diagnosis such as infection. The required action is immediate senior and specialist diabetes input and targeted management of the underlying problem. Exam-focused key message. By 24 hours, DKA should be biochemically resolved. Transition safely with basal insulin first and proper overlap. And if not resolved, assume treatment failure and search for the reason. Potassium management in DKA is a critical, life-saving priority. Both hypokalemia and hyperkalemia are life-threatening. Remember the key physiology for the exam. Serum potassium is often high at presentation, but total body potassium is depleted, and once insulin is started, the potassium level can fall rapidly. Section 1. Potassium replacement regimen. Management is based on the serum potassium level. If potassium is greater than 5.5 millimoles per liter, do not give potassium. If potassium is between 3.5 and 5.5, add 40 millimoles of potassium per liter to the infusion fluid. If potassium is less than 3.5, this is an emergency. Delay insulin, start intravenous potassium replacement first, and obtain urgent senior review. This is a classic MRCP safety point. Section 2. Monitoring and adjustments. Potassium must be checked. At 1 hour, at 2 hours, then every 2 hours. If the result is abnormal, check hourly. When glucose falls below 14 millimoles per liter, consider reducing the insulin rate to 0.05 units per kilogram per hour to reduce the risk of hypokalemia. If there is severe hypokalemia, assess whether replacement is adequate. These patients may require concentrated potassium in a high-dependency or intensive care setting. Section 3. Special situation. Renal failure. In renal failure, potassium is usually not required. The danger here is severe hyperkalemia. Management includes continuous cardiac monitoring, immediate renal team involvement, and dialysis if needed. Exam-focused key message. In DKA, normal or high potassium does not mean potassium is safe. If potassium is below 3.5, replace potassium before insulin. And always monitor potassium frequently and systematically. Now we move to the insulin infusion rate and the metabolic treatment targets. The standard fixed-rate intravenous insulin dose in DKA is 0.1 units per kilogram per hour. This slide converts that into practical weight-based rates for rapid prescribing. For most adults, 50 to 59 kilograms to 5 units per hour, 60 to 69 kilograms to 6 units per hour, 70 to 79 kilograms to 7 units per hour, 80 to 89 kilograms to 8 units per hour, 90 to 99 kilograms to 9 units per hour, 100 to 109 kilograms to 10 units per hour. Patients below 50 kilograms or above 140 kilograms require senior or specialist advice. This is a common MRCP safety detail. Metabolic targets. Assess every hour. Treatment is not judged by glucose alone. You are aiming for capillary ketones falling by at least 0.5 millimoles per liter per hour, or venous bicarbonate rising by at least 3 millimoles per liter per hour, and plasma glucose falling by at least 3 millimoles per liter per hour. These are the true markers of DKA resolution. Inadequate response pathway. If these targets are not achieved, do not immediately increase insulin. Step 1. Check the system. Is the pump working? Is the line connected? Is there residual volume in the tubing? This is a very common real-life cause of failure and a favorite exam trap. Step 2. If everything is functioning correctly and the response is still inadequate, increase the insulin rate by 1 unit per hour, every hour, until the metabolic targets are achieved. Exam-focused key message. In DKA, you treat ketones and acidosis, not just glucose. And if the response is poor, check the pump before the patient, then increase insulin in controlled hourly steps. We now reach a key treatment threshold in DKA management. When the plasma glucose falls below 14 millimoles per liter, you must add glucose, not stop insulin. Start 10% glucose at 125 milliliters per hour. At the same time, consider reducing the insulin infusion to 0.05 units per kilogram per hour if the glucose continues to fall despite glucose replacement, or if there is a risk of hypoglycemia. The rationale is important for the exam. We are preventing hypoglycemia and at the same time reducing the risk of hypokalemia because lower insulin doses slow the intracellular shift of potassium. Special clinical situations. In euglycemic DKA, glucose may already be low or normal. So if glucose keeps falling despite 10% glucose, you should reduce the insulin infusion to 0.05 units per kilogram per hour. In renal failure, insulin clearance is reduced. This creates a high risk of hypoglycemia, so you should consider earlier dose reduction to 0.05 units per kilogram per hour. MRCP key message. When glucose drops below 14, add glucose, continue insulin, and reduce the insulin dose only if needed. Insulin is stopped only when DKA has resolved, not when glucose becomes normal. We now move to a critical safety step in DKA management, the transition from intravenous to subcutaneous insulin. This transition must only occur when all resolution criteria are met. Capillary ketones less than 0.6 millimoles per liter, venous pH greater than 7.3, venous bicarbonate greater than 15 millimoles per liter, and the patient is eating and drinking. Pathway A. Patient already on an insulin regimen. Give the usual subcutaneous insulin dose at the usual time. Then remember the most important exam rule. Continue the fixed-rate intravenous insulin infusion for 30 to 60 minutes after the subcutaneous dose. This overlap is crucial to prevent rebound ketosis and recurrent DKA. After that, stop the intravenous insulin and monitor glucose and ketones every 2 to 4 hours for the next 24 hours. Pathway B. Insulin-naive or uncertain regimen. This requires specialist diabetes team input. The total daily dose is usually 0.5 to 1 unit per kilogram per day, given as 50% basal and 50% bolus. Timing is the same safety principle. Give the first subcutaneous dose, then continue intravenous insulin for 30 to 60 minutes, then stop the infusion. Common errors to avoid. Very high yield for MRCP. Stopping intravenous insulin before subcutaneous insulin is absorbed. Giving an inadequate subcutaneous dose. Poor monitoring after the transition. And discharging the patient before stability is confirmed. MRCP key message. Never stop intravenous insulin at the time of the first subcutaneous dose. There must always be a 30 to 60 minute overlap. This is a recurrent exam favorite and a major patient safety point. We now look at DKA in special patient groups, where standard protocols must be modified to improve safety and outcomes. Obstetric emergency DKA in pregnancy is an obstetric and medical emergency. These patients should be managed in the delivery suite or high dependency unit with joint obstetric and medical care. All treatment calculations must use the current maternal weight, and remember, ketones are directly toxic to the fetus. The key message is rapid treatment, because fetal mortality is significant if DKA is delayed. Young adults, age 18 to 25. This group has an increased risk of cerebral edema. Fluid replacement must therefore be more cautious, with early consideration of HDU admission and enhanced neurological monitoring. Elderly patients and those with heart failure. Here the major danger is fluid overload and pulmonary edema. Give slower and more cautious fluid replacement, reassess volume status frequently, and actively look for signs of overload. These patients often require high dependency care. Renal failure. In renal failure, the approach changes significantly. If the patient is euvolemic, large fluid volumes may not be required, and potassium replacement is often unnecessary. Early involvement of the specialist renal team is essential, and some patients may require renal replacement therapy. MRCP key message. In DKA, one protocol does not fit all. Pregnancy, young adults, heart failure, and renal failure all require individualized fluid and electrolyte strategies with early senior involvement. We finish with the life-threatening complications of DKA and the criteria for escalation to higher levels of care, based on the Joint British Diabetes Society's guideline. Life-threatening complications. The most common cause of arrhythmia during treatment is hypokalemia, which is why potassium monitoring is critical from the start. Hyperkalemia, particularly in renal failure, can lead to cardiac arrest. Cerebral edema, although rare in adults, carries a very high mortality and requires urgent critical care with hypertonic saline or mannitol. A reduced GCS below 8 puts the patient at risk of aspiration pneumonia and mandates airway protection. Acute kidney injury is common, so urine output and creatinine must be closely monitored. Severe DKA or sepsis may precipitate ARDS. Treatment itself can cause hypoglycemia, which is managed with intravenous 10% glucose. There is also a prothrombotic state, so prophylactic low molecular weight heparin should be given unless contraindicated. Large volumes of saline may produce hyperchloremic acidosis, which can mask biochemical resolution. When to escalate. Level 2 care, HDU. Patients require HDU if there is severe DKA, persistent hypotension despite fluids, a falling or low GCS, oxygen saturation below 92% on air, pregnancy, significant comorbidities, or the need for concentrated potassium infusion. When to escalate. Level 3 care, ICU. Immediate ICU involvement is required for GCS below 8, respiratory failure needing ventilation, vasopressor-dependent shock, cardiac arrhythmias, multi-organ failure, cerebral edema, or the need for invasive monitoring. Early warning signs of treatment failure. Failure of ketones to fall by at least 0.5 per hour or bicarbonate to rise by 3 per hour, a deteriorating GCS or persistent hypotension or oliguria should trigger urgent senior review and escalation. Closing exam message. DKA management is not only about insulin and fluids. It is about anticipating complications, recognizing failure early, and escalating at the right time. That is what saves lives, and that is what scores marks in the MRCP exam. Before discharge, our goal is not only biochemical resolution, it is preventing the next episode of DKA. According to the Joint British Diabetes Society's guideline, every patient must complete a structured pre-discharge checklist. Pre-discharge criteria. First, there must be biochemical stability. Blood ketones below 0.6, venous pH above 7.3, bicarbonate above 15, the patient eating and drinking, and stable on subcutaneous insulin. Second, clinical stability. Normal vital signs, no active complications, and the precipitating cause treated. Third, education. Sick day rules must be clearly understood, with confidence in insulin dose adjustment. And finally, a clear follow-up plan. Diabetes specialist review within 1 week and communication with primary care. Prevention strategies. The most powerful tool is sick day education. Never stop insulin, increase glucose and ketone monitoring, maintain hydration, and give extra rapid-acting insulin when ketones rise. Basal insulin must always continue. Patients must have direct access to help, including out-of-hours advice. Recurrent DKA should trigger psychological assessment, as distress and eating disorders are common contributors. Technologies such as continuous glucose monitoring and home ketone testing can dramatically reduce risk. Red flags for recurrence. Certain patients require intensified follow-up. Previous recurrent DKA, HbA1c above 75 millimoles per mole, young adults between 18 and 25, psychological comorbidity, or social vulnerability. These patients need early specialist input and frequent review. Final closing message for the whole video. DKA management does not end when the ketones clear. The real success is preventing recurrence, empowering the patient, and building a safe discharge plan. That is guideline-based care. That is exam-winning practice. And that is how we improve outcomes.